Okay, so we're going to finish up chapter 47, and that's chronic kidney disease or chronic kidney failure. Surprisingly, it's a lot more common than the acute version of it, and it's defined by glomerular filtration rate of less than 60 milliliters per minute. And I just want to remind people that it's not just the 60 mLs, it's actually 60 mLs per minute based off of your body surface area and a constant. But so there's more in there, so don't just get stuck on that number. And it lasts for more than 3 months, or been persistent for more than 3 months. So this is where it's not quite as severe as the acute, but you've had decreased function in the kidneys for a long period of time, whether it be because of blood flow or filtration or inflammation. For whatever the reason is, you've had a decrease in the function of the kidneys for more than 3 months, and that's where you have irreversible damage. So you cannot reverse the damage from chronic kidney disease. You're merely trying to control it. And some of the causes, most predominantly, is diabetes. Diabetes is going to be your number one cause of chronic kidney disease, and hypertension, and that's the same for your acute. But with these ones, the diabetes and the hypertension puts tons of pressure on all of your vascular spaces. So if I've got tons of pressure going, eventually it's back to that analogy of throwing bricks at tissue paper. If I sit there and throw bricks for a long period of time, or even pebbles for a long period of time at tissue paper under enough pressure, I'm going to make holes in it. And that's exactly what's happening to your glomerular filtration. It's basically, it's got so much blood under pressure that it's just smashing into the filtration system in the renal system. And it eventually makes huge holes, and then, of course, it doesn't work. Diabetes ruins all small capillaries. And capillaries are especially around your tubules and all around the whole nephron itself. So when you have those capillaries that are being destroyed by the high levels of glucose, then you're going to have decrease in function. Other things that can cause it is glomerulonephritis, which is inflammation of the glomerulus, cystic kidney disease, and that was a genetic factor where there's tons of cysts that have eroded the kidney. And then the family history is another one that you need to look at too. Obviously, because hypertension and diabetes is more predominant in minorities, specifically African Americans, followed by Native Americans, you're going to have a higher rate of chronic kidney disease in African Americans. Like, it's almost like 5 times higher, and twice as much in Native Americans, and like 1.5 in Hispanics. But so there is a disparity there, which they're big on. All right, so when we have issues with our kidney, we're going to have issues that affect the entire systems, because again, kidneys do so much. They regulate your pH, they get rid of waste, they manage your blood pressure, they manage your fluid volume, they prevent toxins build up in the body. So when you have a decreased filtration rate, like that is as severe as we have with chronic, you are going to have other systemic issues. So the other body systems are going to be affected, and that's the term referring to uremia, and that's where the other systems are affected. And this happens generally when it gets to about a 10 for your glomerular filtration rate, 10 milliliters per minute for glomerular filtration rate. The kidneys are highly adaptable, so a lot of times stuff isn't diagnosed until the very end. For instance, as we get older, we know that we lose kidney function. We know that we lose kidney size, but yet we're able to maintain that somehow. And it's because those kidneys can adapt. So we're able to maintain ourselves because kidneys are very adaptable. So once, just part of the kidneys going out is not going to be affected, maybe not even one. It may be completely asymptomatic, but when you have a huge loss, that's when you're going to find these issues. And unfortunately, that's a lot. Way too late for a lot of people, but anyways. Alright, so the manifestations for this, or the symptoms, are very similar to that of acute chronic disease, kidney disease, and the manifestations are going to be, of course, you have higher waste that isn't getting filtered out, so it's going to be in the body. One I didn't talk about was carbohydrate metabolism, and I'll hit on that. Elevated triglycerides, triglycerides in your body are going to be up, insulin level, and that again relates back to your diabetes, but insulin level is going to be up. And of course, you're going to have your electrolyte because again, kidneys manage electrolytes. So now you're going to have your electrolytes all out of whack, high, low, all over the place. Acidosis because we're not producing the ammonia that binds to the hydrogen, and we also have a reduction in bicarb. Anemia, and that has to do with those erythropoietin, and then infection. Okay, so let's hit on this a little bit. So these are some of the manifestations that you'll see with your chronic kidney disease, and again, they're very similar to that of acute kidney disease, as it should be. You're going to have a high level in waste buildup in the body. That means you also have higher levels of drugs in the body for a longer period of time. So what somebody was originally taking, they may need to take less of. For instance, insulin is going to float around in the body for a long period of time. You're going to have tons of electrolyte shifts like you saw in the acute, and those electrolyte shifts are going to affect your potassium, your calcium. You're going to have the acidosis, like I said, from ammonia. This carbohydrate metabolism, I didn't hit on this before, but basically it's that your body is not going to be able to process carbohydrates the same. And what ends up happening is because you have a high level of insulin or hyperlipidemia, or I'm sorry, you're going to have a high level of insulin in the body, and that's going to create, it's going to stimulate in your body the production of triglycerides. So you're going to have a production of triglycerides in the systems, and when you have that production of triglycerides in the systems, you're going to end up with high, very low density lipoproteins and low density lipoproteins, and a decrease in high density lipoproteins. All right, what does that mean? Okay, so if I have tons of sugar in my system, my body is going to make triglycerides. Triglycerides are not going to be good because it's going to make tons of, you're going to end up with tons of fat in your body. This fat is going to be cholesterol, and cholesterol, as we know, is going to cause significant cardiovascular issues. And that's defined by very low density lipoproteins and low density lipoproteins. Those are the bad ones. We don't want those. Those are bad. All right. What we want is high density lipoproteins, which means that the molecule is mainly made up of proteins and not lipids. These are primarily made up of lipids and not proteins. Basically, this all amounts to the fact that we're going to have huge cardiovascular disease, and that is the leading factor of death for your chronic is cardiovascular disease. That could be myocardial infarction, stroke, chronic heart failure. I mean, think about all those arteries being blocked with cholesterol, and you're pretty much going to have your end result, which is cardiovascular disease and death related to your chronic kidney disease. All right, the other ones, and I just hit on it, but the elevated triglycerides, and that has to do with the high level of insulin in your body. Acidosis, we already hit on. Oh, and anemia. Again, kidneys are responsible for erythropoietin, which produces or stimulates the red bone marrow to make red blood cells. Well, when I don't have good kidney function and I don't have erythropoietin, then I don't have red blood cells, and I end up being anemic, which is going to create all types of bleeding issues all over the place. Bleeding. That's not how you spell bleeding. All right, all types of bleeding issues. You also have low iron in many of these patients, so that's going to only add to your issues. And then infection. The body just simply cannot handle all of this, and so you have a high risk of infection with chronic kidney disease because you've got all these shifts happening, and it's systemic shifts. So that's why we have a lot of infection related to this. All right. So that is chronic kidney disease in a nutshell as far as your causes and your manifestations. The end result, I forgot to mention this, is end-stage kidney disease. And end-stage, as you might imagine, means bad. End-stage is the last stage of kidney disease. And you have a decrease in glomerular filtration of at least 15. There is stages for this, and I'll explain that, but at this point, you're either dialysis or transplant, and that's it. Those are the only options that you have. And again, most people die from cardiovascular disease because of those high triglyceride levels, the high lipoproteins, dense lipoproteins are going to raise the cholesterol, and it's going to build up as plaque, reducing the amount of blood flow, and eventually you'll end up with myocardial infarction or stroke. All right. So how does all the other ways that it manifests itself, and I didn't hit on this as much, but systemic effects also include psychological. So all of a sudden they're laughing, crying, depression. You're going to have that cardiovascular system all jacked up. So you're going to have high blood pressure. You're going to have low blood flow. You might have ischemia, which of course is going to turn into cell death, which eventually will relate to myocardial infarction or MI. You're going to have GI issues, specifically bleeding here. And a lot of that has to do with the lack of blood, iron, things of that nature. You also have nausea, vomiting, and anorexia as well. A general of not feeling well. Your endocrine system is equally out of whack. You're going to have hyperparathyroidism. I'm just going to abbreviate it. PT, but hyperparathyroidism, and because our parathyroid has a hormone which it releases that breaks down bone, we're going to also have osteomalacia, and probably calcium deposits in the skin because we have bone breakdown. All right, neurological, and I didn't hit on this on the acute, but the neurological effects is fatigue, headaches, and it's not listed in this one, but in the acute, it does mention that it will eventually turn into seizures, because it's going to be blocking or affecting neural pathways. So, what else? Oh, I already said increasing blood pressure, edema, and of course, if you can't get rid of that waste, can't get rid of that fluid, you're going to have edema. Edema, of course, going to go back to high blood pressure. Dry skin, which is kind of on the other side of fluid retention, but anyways, dry skin. You're going to have bone breakdown, calcification. You might have calcification on the skin, which is the white patches that are itchy, pruritus, and restless leg syndrome. And that has a lot to do with your electrolyte shifts. Okay. For stages, so let's go through the stages of this. Again, chronic kidney disease is defined by 3 months or more of a low GFR lower than 60. When you're at 10, you are talking dialysis. And again, I've seen it say 100 and 125 as a normal glomerular filtration rate, but it's okay because stage 1 is going to start with 90 or above. Alright, and then from there it's pretty much going in 29s, okay? So there's a stage 2, there's a stage 3, and there's a stage 4, and your last one is stage 5. So if you can remember that stage 5 is going to be 15% or low. This means dialysis or transplant, period. Alright, so then we have all these numbers in between here. So if I can just go in increments of 29, then I'll remember this. So here's how we do this. 20, so we go from 90, and then of course you're going to start at 89 because that was 90. You're going to go down 29, so that's going to leave you at 60. Alright, your next one's going to be 59 because there's 60, and going down 29 from that, that's going to put you at 30. Now this one doesn't make as much sense, but that one's going to be 29 to what it really should be is 16, but anyways. So those are your stages, stage 1, 2, 3, 4, and 5. These are the stages of chronic kidney disease, and again, this is where your 15 is your dialysis or transplant, and that's it. Some of the risk factors, besides being the minority that I already talked about, is going to be a family history, of course, hypertension, and diabetes are going to be your big ones because that's what causes that. Oh, nephrotoxicity, that was the other one. Nephrotoxicity, these can be done by drugs or environmental factors, radiation, or environmental chemicals. And a lot of this right here, for the nephrotoxicity for your drugs, if you can remember, penicillium and gold, that was like two main ones that I saw. Alright, so how do we care for all of this? Basically, we're going to care for this. Again, it's not reversible. We're going to care for this by trying to control it and by trying to figure out, one, what caused it and eliminate some of those causes. Okay, so some of the causes, again, were hypertension and diabetes. So we need to manage those pretty well to make sure we don't have any further damage. We're going to have to manage the extracellular fluid because, again, you have edema and that creates congestive heart failure eventually. You can have respiratory issues with extracellular fluid as well. Nutrition. Now, this nutrition is going to be based off of what are our electrolyte values and what do we have, because if you have high calcium, I'm not going to give you more calcium. I'm going to give you something to get rid of the calcium. Right? So this depends on the electrolyte values. That is patient dependent. But yeah, it could be calcium or it could be potassium or it could be sodium or sodium restriction. Of course, fluids, we need to figure out if they're going to retain fluid or if they're dehydrated. We're going to have to fix that erythroprotein because that'll lead to anemia. And that was the production of red blood cells from the kidneys, or the stimulation at least. We need to control antihypertensive, so we need to control that high blood pressure. We need to get the blood pressure down. That's going to be huge. We have to adjust the drug doses, adjust drugs, because again, insulin is going to float around the body. Other drugs will float around the body, and eventually it can become nephrotoxic. Even if we're trying to treat it, it can become nephrotoxic because it's been floating around the body for so long. And then, of course, dialysis and transplant will be our other options. So we're really looking at our patient's factors and trying to figure out, okay, what caused it? Maybe it was the blood pressure, or maybe it was the diabetes. And if it's the diabetes, then we need to treat that. All right, so what's our role as an RN? RN role is going to make sure that the patient understands what has been causing it. They need to know what the electrolyte balances, hyper and hypo, look like. So, hey, this is what happens if you have too much calcium, too much potassium, too much sodium, whatever. They need to know about specific things to come back to the doctor with. So if they are at risk for high potassium, then they need to know that, heart changes, cognitive changes, retention fluid, those are all going to be important, and they need to know that. So health promotion involves identifying risks. So if I have a patient that has high blood pressure, then I'm going to want to talk to them about lowering their blood pressure and about possible signs of kidney malfunction. Okay, I want to ID those risks. I want to get them screened. So once I've identified that they're at risk, then I want to continue to have them screened to make sure that they have good kidney function. And again, creatine is not a reliable, creatine is not a good way to go. Neither is BUN. You can use creatine clearance. You can use creatine clearance. You can use some of your other proteins, but these ones can be affected by way too much. So creatine clearance is probably your most accurate representation of GFR, and that's going to measure. Remember the creatine clearance measures how much creatine is in the blood over how much creatine is in the urine. And creatine should be coming out in the urine. If it's not, then we have an issue. So it's a comparison of blood over or divided by urine, and that gives you your creatine clearance. What else? We want to treat the hypertension if they have that, or the diabetes. We also want to teach our patients nutrition. Nutrition, again, is patient dependent. They need to know their levels and what they're low or high in to make sure that we're recommending the right thing. Make sure that they have a fluid and not too much fluid and not creating falling or hypovolemia. Signs and symptoms, signs of having an electrolyte imbalance. Right? So you're going to need to know that. They need to make sure that they know that their drugs can be more toxic. We need to make sure that they are being screened, that they're weighing themselves, because that's a good indication of fluid retention, at least at home. Confusion, lethargic, weakness, things of that nature. Depression, of course, is going to be another sign. So as we talk about nutrition, let's talk about potassium, because that's huge. And again, it directly relates to the heart function. Having high or low potassium can really mess you up. So when you're thinking about nutrition and potassium, it boils down to this. If it's yellow, orange, or green, it probably has potassium in it, bottom line. Alright, there's so many different ones that it's hard to nail it down, but yellow, orange, or green are, obviously we have, if you can think about apricots, bananas, oranges, we're thinking about cantaloupe, we're thinking about orange juice, we're thinking about yams. Greens are going to be your spinaches, your cabbage, things like that. Avocados. Some ones that don't apply into this are potatoes. Potatoes are, first of all, if they have high diet, if they are diabetic, do not tell them to take potatoes in. It is horrible. It's very, 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 very high on the glycemic index. Horrible. But whatever. Mushrooms. So potatoes, mushrooms, there's a couple other ones though. Oh, chocolate. Not yet. Yay, chocolate. Your brands or your oats, granolas, and beans are the other ones. So these are the only ones that really don't fit into what I just said, yellow, orange, or green. Potatoes, mushrooms, chocolate, brown. And obviously, again, don't tell somebody diabetic to eat chocolate and potatoes. And the other one was prunes. So, alright, so that is chronic kidney disease. Again, the difference between chronic kidney disease and acute is that acute is rapid, it's severe, chronic is ongoing, longer than 3 months, is irreversible, and your biggest risk factors are going to be diabetes and hypertension. And usually people will die of cardiovascular disease related to high triglyceride levels caused by an increase in the insulin. Okay, and that is chronic kidney disease.